Thank you for asking me to talk to this very sad topic of farewell to BHR.
Happy birthday, BHR!
This man is very active, happy with his BHR, he skis and does other sports. Here is that man's X-ray series, and everything's great at 25 years, and he's due his 30-year X-ray in 2 years' time. Of course, I could not go straight to BHR, and I had to discover through prototypes what would work. And before 1991, hip resurfacing didn't work at all. We tried press fit, both sides. We tried hydroxyapatite, both sides. We tried cement, both sides. And then it became obvious that an uncemented hydroxyapatite coated cup and a cemented femoral component were best. What have we learned from the hip resurfacing era? I've come up with some commandments, and the first one is thou shalt not ignore other researchers' work. And I ignored Martin Elloy's work for far too long. I should have been talking to this man in 1980 rather than 2019. And he developed the first chemical cross-linked polyethylene for hips in order to facilitate injection molding and mass production. He used short chain polyethylenes, and when he cross-linked the components, all the short chains turned into one giant molecule of polyethylene. He had everything in it. He had antioxidant, he had no radiation, and he was able to cross-link it and sterilize it by autoclaving. Wroblewski published his results at 10, 17 and 28 years, and the results are terrific. This picture does tell 1,000 words. On the left, cross-linked polyethylene, no visible wear. On the right, conventional polyethylene, gross wear. Depuy acquired Thackeray's in 1990. Martin Elloy was told to throw his cross-linked polyethylene development in the bin. Why? Because Depuy had worked with DuPont to develop what they regarded as the best polyethylene in the world. What was it? It was Hylamer, and in use it was an international disaster and had to be withdrawn. Orthopedic surgeons were deprived of cross-linked polyethylene for 10 years between 1990 and 2000. Had I known about cross-linked polyethylene, I would never have resurrected metal-on-metal bearings. I regard hard on cross-linked polyethylene bearings the best for joint arthroplasties. Thou shalt not kill. And we all did a lot of killing. And we are still killing when we do total hip replacements. The lowest mortality in match groups is hip resurfacing, followed by uncemented total hip replacement, followed by cemented total hip replacement. Oxford had available all these confounding factors that they were able to adjust for in their matched groups. On this normal transesophageal echo, there is obviously no embolization. When we do a BHR, there is still no embolization. Why is there no embolization with BHR? I developed suction venting of the proximal femur through the lesser trochanter, and this is in the operative technique of the BHR manual. In addition, I taught 3,500 hip surgeons how to do this. This is what happens after you've put in a cemented total hip replacement. There is massive embolization into the right heart, which continues between 5 and 20 minutes. When the blood emerges from the lungs into the left atrium and left ventricle, there is no embolization seen. So the fat and marrow gets jammed in the pulmonary circulation. Siggy Hoffman showed that when you insert a cemented total hip replacement, below the cement restrictor, the pressure rises to 1,400 millimeters of mercury. That's car tire pressure. Many years ago, I attached a car tire to a cadaveric femur. When the pressure is switched on, massive amounts of fat and marrow pour out of the femur. This happens in all our total hips. It's just covered up and we can't see it. With total hips, I tried to vent the distal femur but it did not work because of dense cancellous bone. These 4 drawings show a proposed method of venting the femur during cemented total hip arthroplasty. First of all, the cement restrictor has a hole in the centre and a skirt. Then into that central hole we place a PMMA tube and we attach a sucker to the top of the PMMA tube. Then we inject cement into the femoral canal and we pressurize it. Then we attach the femoral component with a central hole up the component to the top of the PMMA vent, and now we suck in the top of the femoral component. The femoral component is then inserted, sucking all the while with suction at the top of the femoral component, and when the fat and marrow stops coming out of the sucker, then we can replace the sucker for a screw-in bung. Thou shalt not perform an unstable THA. The best information on this topic comes from Richard Van Arkel and his colleagues at Imperial College London. This is their rig, and they dissect the hip, leaving the hip capsule intact. What they really wanted to do is to put a hip replacement in without touching the hip capsule, and Sarah Muirhead-Allwood discovered the solution. She had the brilliant idea of cutting a hole through the floor of the acetabulum, leaving the hip capsule totally untouched. You can see the capsule here, perfectly intact, and it closes down like the iris in your camera and extension. In the center, in yellow, you can see on 8 cadaveric hips the internal and external rotation of the normal hip. Then they put in 28, 32 and 36 millimeter headed hip replacement and did the range of movements again. And there is a massive increase in the range of movement of the hip. The range of internal rotation increased 40 degrees, and that puts the hip vulnerable to impingement and posterior dislocation. With extension and external rotation, there is increased range of movement, and that puts the hip vulnerable to an anterior dislocation in extension. This is the sort of hemiarthroplasty I would want if I sustained a displaced subcapital fracture. The head shells come in ceramic or polished metal, and as the heads increase in 1 millimeter increments, the neck also increases, and the combination of head and neck will fill the hip capsule. I did a series of ultra-short stem hips starting over 20 years ago, but I had to stop when I'd done 288. This is very useful for this man, age 23, with avascular necrosis of his femoral head. This is also useful in many women with poor bone quality of their femoral head and in biologically older men with poor bone quality of their femoral head. If you risk doing a resurfacing in the face of poor femoral head bone quality, you are asking for a glut of fractures of the cancellous bone of the femoral head. I had to stop because of a handful of cases of severe wear of the head-neck taper. How can you get this fully ingrown stem out safely? Cut with a one-sided reciprocating saw all around the neck. Then we can chip away proximal bone without risking a crack travelling down the neck you are wanting to preserve. Then you can insert a chisel down alongside the femoral component and eventually take the implant out. Here is that ingrown and ungrown implant removed without damaging the femur. The modern version of that stem is a stepped implant with an ingrowth surface, and instead of a taper we have a fixed head, and on top of that is a rotating only dual mobility cross-link pulley top. We are still able to vent the femur through the lesser trochanter to stop embolization, and since the stem of this implant does not go into the shaft of the femur, we're not going to get stress shielding of the femur. The first maneuver is to cut the head off at the head-neck junction, and this is very useful for access in those who like to do limited access surgery getting to the acetabulum. I've drawn a second line at the mid-neck level, and between those two lines is the perfect circumstance for bone ingrowth. You have a tapered implant going into a tapered tube of cortical bone which is filled with dense cancellous bone. However, if you try resecting at the mid-neck level and putting an implant in there, then you have a really bad circumstance for bone ingrowth because you're putting your implant into a diverging cavern. Thou shalt not poison your patients. Regarding chromium and cobalt, please visit Hina Ziai's poster session to see her amazing 23-year longitudinal iron study. It is perfectly understandable to try and get rid of metal ions completely. And a lot of surgeons are keen on doing a ceramic-headed implant to try and get rid of metal ions. But unfortunately, it doesn't work. In the early days of modular heads, the neck taper was perfectly smooth. Today, the neck taper is deliberately not smooth. It has a fine microthread on its surface, and this microthread is there to prevent fractures of our precious ceramic heads. But that threaded neck taper turns out to be a problem, and I'll show you the evidence on this. This was first shown in a simulator study in Newcastle in the UK, and the neck taper gets damaged during 5 million cycles of where proximal superior and distal inferior, where then those red blotches are. We can see these damaged areas on the neck taper by simple magnification. You can see it at the top there, and then further down on the inframedial aspect, there's another worn area. You can see the undamaged microthread on the neck taper on the top left on this zygo picture. But on the bottom left, you can see an area where the neck taper is seriously destroyed. These microthreads are present on every neck taper today for the simple reason that they're there to try and prevent ceramic heads from fracturing. Instead of the head fracturing, the head crushes the micro threads, and that's where the crushing comes into play. The problem with microthreads is that it removes a lot of support from the metal neck for the ceramic head, and that's why you can get extensive crushing and metal ion production from the neck taper. When I saw that simulator study from Newcastle, I knew that there would be metal ion implications in patients, and my team joined with Andrew Shimon, and we looked at his ceramic total hips with one acetabular component and 5 different stems. Delta ceramic contains chromium and strontium oxides. The fact that chromium and strontium are not elevated in the patient's serum means that there is no evidence of damage to the ceramic. The same cannot be said of titanium and aluminium, which is significantly elevated in the patient's serum. This confirms that the neck taper is being damaged. Elevated blood titanium levels may be safe, but elevated aluminium levels are most likely not safe. We know about aluminium as a neurotoxin, and the early renal dialysis machines could not remove aluminium, and the patients on dialysis gradually became demented, and this was called dialysis dementia. If you'd like to mug up on the effects of aluminium, this is an excellent Kindle book to buy. Aluminium crosses the placenta, and aluminium is freely excreted in breast milk. So if this woman gets pregnant, the baby is mainlining aluminium. When the baby is born, then they will get even more aluminium in breast milk. For adults, the risk of chronic elevated aluminium exposure is dementia. For damaged children and damaged adults, this may well turn into a major medical legal problem. Please take a photo of this QR code, and that will give you a 1-hour video on everything we learned from the metal on metal hip resurfacing era. I thank you for your attention.